Fluid Deresuscitation in ICU, why, when and how? Please welcome Dr. Ravidra Ghavat sir for the discussion.
Now we need slides also. Can I have the presentation? So fluids are something which have been routinely used, and like my earlier topic I was talking about, nutrition and fluid are the two most disregarded topics in critical care. As I said, we only focus on antibiotics. So why do we give fluids? The main objective of giving fluids are two. One is to maintain organ perfusion. And how do we maintain the organ perfusion? By giving fluids, we try to increase the cardiac output and the tissue oxygen delivery system, right? Or the tissue oxygen. Though it looks very simple, but it's a very complex topic, right? Because fluid has to be treated as drug, and we don't do that. It has to have a right time, right amount, and right duration. And same, we also need to stop it when it is not required. In fact, we must think, we always think that fluid is always used for resuscitation, right? But in fact, only 6.5% fluid has been reused for resuscitation, and most of it has been used as maintenance, almost 25%. And 40% of the chunk that we use in the ICU, that fluid usage is constituted by nutrition and carriage fluid, like for giving antibiotics, for giving drugs, and so on. I will make a very bold statement here that fluids are the most disrespected, disregarded, and overused drugs. And that is because 50% of the time we forget to stop fluids or modify them. They just continue like that. Once we start at 100 ml per hour, it just continues like that at 100 ml per hour. And studies have shown that 2 to 4 liters of fluid is accumulated by second day of the ICU stay of a patient. And excessive fluids produces a syndrome like SIRS, which is called as GIPS, Global Increased Permeability Syndrome, which happens because of exacerbated glycocalyx degradation, endothelial injury of the vessels, capillary leakage, and it leads to a severe inflammatory state. What is fluid accumulation? Fluid accumulation is any fluid when it accumulates in the body by 5 to 10%. So if you have an increase of body weight by 5 to 10%, it is called as fluid accumulation. Is fluid accumulation and fluid overload same? No, it is not. No, they are different terms. Fluid accumulation is when the weight increases, whereas fluid overload is when you cannot give any more fluid at all. Like the patient develops symptoms of pulmonary edema. There are B lines, the patient desaturates. This is fluid, or any other problem in other systems. We'll come to that. And what is fluid accumulation syndrome? When fluid accumulation, that is 5-10% weight gain, is associated with an organ failure due to fluid accumulation, then it is called as fluid accumulation syndrome. Okay, so that usually in the septic patient, this is the triad vicious cycle that we face. You give fluids, you resuscitate, they get over-resuscitated, dehydrate, and again hypotension, and so on. And it causes edema in every system. So what is the problem with this fluid? If the fluid gets accumulated, almost all systems it can affect. It can affect the respiratory system, cardiovascular, it can cause cerebral edema, it can cause edema in the gut, it can cause abdominal compartment syndrome, it can also cause hepatic congestion, it can also affect the kidney because of backward changes, swelling, right? So almost interstitial edema in the kidney, it can cause acute kidney injury and acute kidney failure as well. So what it tells us is that fluid does hurt, right? It's not that easy. So fluid hurts, right? And this has been proved in most of the studies, like whether it is in ARDS, whether it is in AKI, whether it is in sepsis, or in post-op patient. The FACT trial, right? It told us about that fluids are not good in ARDS patients, right? The classic trial and the SOAP and the WAS trial, all of them have concluded that excessive fluid is not good. In fact, laser is the better one. Then do we need to, that is why we need to think about a strategy where we can de-resuscitate, or where we can decrease the fluid intake, or we can actively remove the fluid so that we can avoid all those deleterious effects of the fluid. And this term was first coined by Malbon et al. In 2014, where deresuscitation was defined or was meant as active fluid removal after stabilization. So if you are actively removing the fluid, it is called as deresuscitation. Whereas de-escalation is when, if you are giving, suppose 100 cc of fluid, you stop that fluid, that is de-escalation. It is like, stopping the antibiotics. So that is de-escalation. If you are giving 100 cc and then you decrease it to 40 cc, is de-escalation. So those are different terms. What are the triggers? When will you stop, when will you start fluid resuscitation, right? When will you de-escalate or stop giving fluids or decrease the fluid, or will actively remove the fluid? There are some clinical signs like weight gain, cumulative positive fluid balance. Every day you must look at the positive balance. Then other laboratory indicators like, hemodilution. If the hemoglobin is dropping, your hematocrit is dropping, and the patient is fluid overload. There is cardiomegaly. Now bedside sonography is available. You see B lines on the sonography in the lungs, right? The patient is desaturating. Or if you have achieved your hemodynamic targets, that there is no responsive to the fluid, there is loss of fluid responsiveness. Your left heart pressures, if you have a pulmonary capillary wedge pressure, if you are measuring, they are optimized. The filling pressures are optimized. There is no response to the preload anyways, or the pulse pressure has decreased, or there is a terminal organ failure due to fluid removal. Now there is a difference between fluid responsiveness and fluid tolerance and intolerance, right? Fluid tolerance. What is, again, as I said, fluid responsiveness is when you give fluid and the hemodynamics improve, right? You would see that the tachycardia has gone down, the mean arterial pressure has gone up. Okay, good. The urine output has improved. The lactate probably has gone down, and so on. The capillary refilling is also better. But some patients, suppose they have an ejection fraction of 20-25% or less, though their hemodynamics would improve after giving fluids, or patients with ARDS, that their saturation might drop down, right? So they are not tolerant, though they are responsive, but they are not tolerant. So we must be able to differentiate between fluid responsiveness and fluid tolerance. And there are many other things that you can look at. Though those parameters are little difficult to make out, the other ones, because they would require a pico. These ones would require probably a pico, but then simple ones like IVC, the vexus, bedside vexus, the central venous pressure, the pulsating femoral Doppler, all these things can be looked at. But importantly, we must remember that fluid responsive is not equal to fluid tolerance, right? That is the basic. Now again, the typical scenario of this is the fluid resuscitation and fluid accumulation, and the problems is a patient of trauma, where we do what is called as a cyclic hyperresuscitation. So the patient is bleeding, you give fluids, the BP increases. As the BP increases, the bleeding starts further again. The patient bleeds again, then again you give fluid. So the cycle doesn't stop, right? So rather than having those targets, what is important is to have physiological markers of perfusion. You need to target the mental status, you need to target the urine output, you need to target the capillary refill time, rather than targeting CVP or mean arterial pressure. So ultimately what you want is the effect, right? Whether your patient is getting perfused well. And these are the markers of perfusion. These are the markers of perfusion that you need to look at, rather than the upstream parameters. You need to look at the downstream parameters of resuscitation. So the principles of fluid resuscitation are that you need to decrease the cardiac preload. You want an improvement in the microcirculation, interstitial edema needs to decrease, the vascular permeability or the syndrome has to be maintained. You also need to take care of the electrolyte, and of course you need to look at what techniques you are going to use to de-resuscitate and decrease the fluid intake. So there are two ways you can de-resuscitate. One is the pharmacological method and the second is the mechanical method. So pharmacological method is the easy one. The first one is to not escalate things or de-escalate things, like restrict your fluid intake. You can concentrate your feed. Suppose you were making a volume of 1 kilocalorie and per ml of kg or 1 ml per kg of solution, then you can actually give 2 kilocalories or 2 ml of feeds to so you can actually concentrate the feeds, right? Suppose you are giving 100 ml per hour through the Riles tube, you can give 50 ml per hour, but with the same calories and same amount of intake and protein, right? So you can concentrate the fluids, you can decrease the fluids, you can make the dilutions in 50 cc and 25 cc rather than making them in 100 cc, right? So all those things can be done, or then you can actively use pharmacology agents like various types of diuretics, the loop diuretics, the acetazolamide, the aldosterone receptor antagonists, the thiazoids, right? So all these things can be used, and you can also use albumin with diuretic therapy, and it has shown that it is synergistic when you use albumin, diuretics and PEEP. And in this study, they have shown that when you use PEEP with some amount of PEEP with albumin and diuretics, it has shown a better outcome in patients who had an increased intra-abdominal pressure, right? So it decreased the extravascular lung water index, and it also decreased the intra-abdominal pressure, and they had an improved clinical outcomes. If the patient is diuretic resistance, right? So then what do? So which are the patients who would be diuretic resistant with there is a problem with absorption, the gut is distended, the kidney functions are deranged, or there are some drug interactions, with diuretics, or patients with AKI and overload, patients with oliguria, and especially the patients are hemodynamically unstable and you gradually want to remove fluids, then you should use what is called as CRRT, right? So renal replacement therapy, and titrate the rate to avoid hypoperfusion, so that you can gradually remove fluid. So especially when the patient is hemodynamically unstable, you should use continuous form of dialysis rather than intermittent form of dialysis. So the other method, as I said, is mechanical dehydration. So you can use CRRT, of course, then others are SCUF and RRT, the routine RRT, if the patient is hemodynamically stable. So both continuous and intermittent can be tried. The advantage are that these therapies are more effective than diuretics in achieving fluid negative balance, and then you can have a constant rate, you can manage the constant rate. So especially in hemodynamically unstable patient, and suddenly you would not like hypoperfuse the patient, you can do gradual deresuscitation. Gradually you can remove the fluid. And this is the early dye studies. What should be the dose then? The early dye study has used 2 ml, people have used from 2 ml to 10 ml per kg per hour of UF removal on dialysis. And what most of the studies have concluded in together is that 2 to 6 ml per kg per hour is a reasonably safe dose to remove the fluid. Now once we have started deresuscitation, at some point you would have too much of deresuscitation where the patient becomes hypovolemic, maybe hypotensive, or you see deleterious effect of deresuscitation. And this is when you have to actually stop deresuscitation. Now we need to know when we should stop deresuscitation as well. That now this is the time, that's it, right? So once you are a target, so you're achieving a predefined goals. If you have a predefined goal of making somebody negative to this much ml, right, or achieving an equal balance over a period of 5 days, okay, that is when you should stop it. Or some physiological targets like central venous pressure, IVC, and whatever you have said. Or you wanted to extubate a patient, and because of fluid accumulation you could not extubate the patient, or you couldn't wean the patient. So once that target is successful, you could extubate the patient, you should stop deresuscitation. Or the oxygen target, if the oxygenation was not good and after deresuscitation you have achieved your target of oxygenation with minimum FiO2, then when you should stop deresuscitation. There are many other things that you can look at, like mean arterial pressure, the SVO2, the PPV and SVV. Most of the time they are not available, but definitely mean arterial pressure. The positive leg rising state, which is a simple tool, whether the patient is responsive or not responsive. If the patient is not responsive, that means that now you have to stop the fluids, right? And the lactate levels. I'm going little fast because I was told so. We are short of time. So basically you need to look at the hemodynamic stability. If deresuscitation causing hypotension, then low dose vasopressors can be installed, and you can start low dose vasopressor to maintain the blood pressure, right? Measures such as halting fluid removal on dialysis, increasing vasopressor doses. Sometimes you can administer albumin to maintain the mean arterial pressure, and that's how you can manage when the patient is getting hypoperfuse or hypotensive because of your active fluid removal. 2 trials deserve a mention here. One is a classic trial 2022, which showed that conservative fluid strategy is safe post deresuscitation, and the RUDDER-2 trial, which is come in 2023, which also said that protocolized deresuscitation is safe and feasible. So friend, deresuscitation is safe, But very important, as I said, that fluids are very disregarded and we don't look into that. So fluid stewardship, like we do antibiotic stewardship, nutrition stewardship, fluid stewardship is very important. And the rule of 4 needs to be remembered and maintained. 4 Ds of drug, dose, duration and de-escalation. 4 questions for us to answer, right? We must ask ourselves these 4 questions. When should I start the fluid? When should I stop the fluid? When should I when should I start deresuscitation? When should I start removing the fluid actively? And when should I stop deresuscitation? That when I started actively removing the fluid, when should I stop that? Right, 4 indications: resuscitation, maintenance, replacement, and nutrition. Very important. Fluid creep needs to be taken into account, as 40% of our fluid goes because of the carriage and nutrition. So that needs to be looked into. And 4 phases that we know, like resuscitation, optimization, stabilization, and evacuation. Last 2 slides, I think. What is the future and the challenges? There is no universal consensus on optimizing timing or parameters for deresuscitation. It is still budding, and variability in patient response to fluid removal, the risk of diuretic resistance in patients with poor kidney function. These are the challenges. And what are we looking at as in the advances in practice? Vector scoring, whether that would help us in better deresuscitation or better manage of fluids. Bioimpedance and AI tools, they are coming up. We just had a discussion on how AI can be integrated into practice, and whether that would help us in fluid status prediction, and whether that would help us whether to give or not the fluids. The precise CRRT protocols, better CRRT protocols, digital fluid dashboards and smart ICU alerts, and sequestration referral buckets. Rather than using one diuretic, we can use 1, 2, 3 diuretics which are going to act at different levels, and sequentially we can try that. So this is a summary of what we do. Identification of patients suitable for fluid removal. Are there signs of fluid intolerance? Are there signs of absence of fluid responsiveness? Patient is hemodynamically stable. Then you start the process of safe fluid removal. Methods are again diuretics and ultrafiltration, and doses as we discussed. And what should be your target? Within your safety limits, mean arterial pressure, CRT, the capillary filling time, and the lactate. And if the patient becomes hypotensive, you can increase the vasopressor dose or start a small dose of vasopressors and adjust your fluid removal. Like weight is not good, oxygen is not good, mobile is, none of this is good in excess. Antibiotics, rain, wisdom, intelligence, even in love, excess is not good. So how can the fluids be very good, right, when they are given in excess? So friends, please take care of fluids in the ICU for your patients, and keep yourself hydrated, but at the same time dehydrate the patient when they are overhydrated. Thank you so much.